Hi class, another highlight disease covered in the cardiovascular system is HIV/AIDS. HIV stands for human immunodeficiency virus, and AIDS stands for acquired immunodeficiency syndrome. Generally speaking, the pattern is first a patient contracts this virus, HIV, and then over a period of time, their white blood cell count goes down, and eventually they develop AIDS. The moment someone becomes infected with HIV doesn't mean they instantaneously have AIDS. It takes a little bit of time. An old term, an antiquated term that used to be used to refer to this infection is GRID, which stands for gay-related immunodeficiency. This term is misleading primarily because this disease can occur in individuals that are not gay, not homosexual. However, if you're reading literature from the early 1980s, particularly from 1982 to 1986, the term GRID was very commonly used. So for any of you that go back to do a literature search, if you ever see this term GRID, I want you mentally in your mind to substitute it with HIV AIDS. That's the current name for the disease. Some of the signs and symptoms of HIV AIDS include a wide variety of diseases manifesting themselves that are associated with this immunodeficiency virus. The symptoms of HIV have been tied directly to two very specific things, though, regardless of which disease is manifesting itself. First, we need to have the virus present within the bloodstream, and then finally, we need to look at the levels of T lymphocytes within the bloodstream. And as the levels of T lymphocytes in the bloodstream will change over the course of the disease, we'll take HIV and advance it to the next level of AIDS. The initial symptoms associated with infection by HIV include fatigue, diarrhea, weight loss, some neurological changes, and just overall general malaise. And then we start to have lots of opportunistic infections appear. These opportunistic infections are normally not going to manifest themselves in healthy individuals, but are going to start to preferentially appear within subpopulations that have HIV/AIDS. One of the reasons why there's this old antiquated term that refers to the disease was because the very first populations that first started to manifest the symptom were populations of homosexual men within San Francisco that had very rare diseases manifesting themselves, such as Kaposi sarcomas or Kaposi sarcomas, which is an incredibly rare form of cancer. So as we look at the initial infection rate, right here at day 0, we'll be initially infecting the patient with the virus. And the virus will be circulating through the bloodstream, so there will be viremia, and the concentration of the virus skyrockets over the course of the first 2 weeks, and then starts to level out again. And this time period right here is variable. It depends on the anti-HIV medications the patients are receiving and their own natural immunity to the virus. And this is the variable time period that separates HIV from full-blown AIDS. So the number of years between infection of HIV and the development of AIDS will vary from patient to patient. Now, initially, there's going to be a spike in the virus, and then the virus drops off again. That initial spike in the virus is going to cause our body to start to make antibodies that will target antigens specific to HIV. And those concentrations of antibodies are what we commonly use as an indicator test for HIV. So it's one common method to confirm a diagnosis of HIV is a serological exam that examines the blood for the presence of HIV antibodies. Over the course of the infection, though, we find that the level of CD4 positive T lymphocytes within the blood steadily decreases. And as that CD4 positive T lymphocyte goes down, eventually it drops below the threshold of 200 T lymphocytes per microliter of blood. And once we drop below that threshold, we recategorize the patient from HIV positive to AIDS positive. So we need to have that T lymphocyte level drop below 200 cells per microliter of blood, or 200,000 cells per milliliter of blood. There are some illnesses that are classically associated with AIDS. We'll talk about those on another slide. They are in table 18.3 of your textbook. All of these illnesses are associated with infecting a patient that has a compromised immune system. These diseases generally do not appear in patients that are healthy. Some other symptoms that are associated with HIV/AIDS include very severe immune system dysfunction. This immune system dysfunction goes hand in hand with hormonal imbalances and several metabolic disturbances as well. There's going to be a very noticeable wasting of the body mass of an individual that's HIV positive. Particularly, if we look at the patient's GI tract, HIV/AIDS has a very hard impact on our digestive tract and causes the digestive tract to malfunction and not absorb as many nutrients. And this goes directly to and leads directly into that chronic wasting of the patient's body mass. There's very protracted periods of fever and fatigue, general malaise, sore throat, night sweats. These are all symptoms that get progressively worse and worse as HIV progresses to full-blown AIDS. There's also some generalized rashes that can occur within the patients, lymphadenopathies, and can occur in several chains of lymph nodes as well. If we look at these diseases that can be associated with HIV/AIDS, they can include cytomegalovirus retinitis, causing the patient to lose their mind. We could have Burkitt's lymphoma. We can have cytomegalovirus affecting our liver, spleen, or lymph nodes. We can have tuberculosis, recurrent pneumonia. We can have herpes. We can have yeast infections of the trachea and the bronchi and lungs. There are a wide variety of diseases associated with a compromised immune system that are characteristic of being HIV positive. It's not to say that these diseases cannot manifest themselves in a patient that does not have HIV, but generally speaking, these diseases are indicator species. So they don't mean that a patient absolutely does have HIV, but it should cause you to raise an eyebrow and go, The presence of this disease usually means they have a weakened immune system. Here's the classic Kaposi's sarcomas. Some of the very virulent forms of HIV/AIDS can also have some very distinct neurological effects as well. This disease can lead to lesions within the brain that is going to be associated with a loss of neurological function. We could have meningitis or lesions within the meninges form. The spinal cord and peripheral nerves can also be targeted by HIV. Patients that have nervous system impairment usually are going to show some withdrawal, some memory loss, some sensory loss, and AIDS-based dementia. Some of these signs and symptoms of the nervous system are based off the fact that we have HIV-induced encephalopathy. Or in other words, HIV causes part of the brain to die off. We can have lymphoma manifest itself in the brain, or we could have toxoplasmosis manifest itself in the brain. Toxoplasmosis is a pathogen that most adults within the United States are infected with or exposed to at least on a regular basis. And if we have a fully functioning immune system, it's not a big deal. But if we have a compromised immune system, then it can start to destroy our brain tissue. HIV is caused by a retrovirus. When I say retrovirus, I mean that its genetic information goes from RNA back to DNA. It's retrograde, so to speak. It goes opposite of the normal path of progression of DNA to RNA to protein. And after we go from RNA back to DNA, then we go back to RNA and then to protein. So HIV is caused by a retrovirus within the genus lentivirus. All of these retroviruses have the potential to cause cancer. They typically are going to be associated with very fatal diseases and are capable of altering the host genetic or the host nuclear genome or the host DNA. All retroviruses are going to contain the enzyme reverse transcriptase. It ends with an ACE. We know it's an enzyme. What does this enzyme do? It does transcription in reverse. So when we go from DNA to messenger RNA, or from DNA to RNA, that's called transcription. Remember, we had transcription and then translation, DNA to RNA to protein. If you go from DNA backwards to RNA, that is reverse transcription. Wow, I really need to calibrate this smartboard. And reverse transcription is done by the virus, or the enzyme, reverse transcriptase. So this reverse transcriptase is going to catalyze the production of DNA from single-stranded RNA. Our retroviruses are going to permanently integrate their viral genome into the host genome, which means that even if there are no viron particles free-floating within the host, because that virus has integrated its genome into the host genome, it can reemerge and remanifest itself several generations of progeny cells later. Some of our retroviruses are actually going to cause a transformation of our cells, making our cells malignant or cancerous. This occurs when the retrovirus is going to alter particular host genes or onconogenes, genes that can regulate or initiate a cancerous cycle within a cell. HIV is an enveloped RNA-based virus. It's enveloped meaning that there's a coating of lipids outside of its capsid, so its outermost layer is a lipid envelope. It also is going to have a glycoprotein spike that's going to perforate its envelope, and it's going to allow for that virus to dock with its target cells and fuse and be absorbed within those target cells. It can only infect host cells or target cells that have both CD4 plus a CCR5 co-receptor manifesting on the surface of those cells. And that once that virus gains access to the cell, it can start reprogramming the cell. There are several kinds of leukocytes and other cells within our body that can be infected by this HIV virus. So here we can see the classic structure of HIV is a roughly spherical viron particle. We'll have a protein-based capsid coat within the virus. That capsid coat is going to be covered by the lipid-based envelope that has its carbohydrate receptors on its surface. Those carbohydrate receptors are going to bind with CCR5 and CD4 on a host cell to initiate fusion. And within the virus, we are going to have our reverse transcriptase. We'll have the integrase enzyme. We'll have a protease enzyme. And then we'll have the segment of RNA. So there are 4 ingredients within the capsid that make up HIV. HIV is capable of entering mucous membranes or through the skin directly. It's very easily able to penetrate mucous membranes. One of the reasons why it's so easily able to penetrate mucous membranes is that our mucous membranes are much thinner than the epidermis or epithelium that makes up our typical skin on the surface of our body. And those mucous membranes are going to have regions like PAMPs like malts that allow for the immune system to be directly exposed to the mucous membrane, thereby giving that virus easy access to the lymphocytes that it preferentially likes to infect. Our virus is also capable of growing within dendritic cells, so that's another cell type that the virus likes to infect, and we have high concentrations of dendritic cells that line the mucous membranes of our body. Recall, we have lots of mucous membranes in the digestive tract, and there are also quite a few mucous membranes present within the vaginal canal as well. As that virus is amplified, it's going to reproduce within macrophages in the skin and within the lymphatic organs, bone marrow, and blood. It's going to continue to preferentially infect cells that have both that CD4 marker and the CCR5 marker. Helper T cells are particularly hard hit by this virus. And as the helper T cell population within the body decreases, the coordinated adaptive immune response is also going to decrease as well. Our virus is capable of docking to the surface of our host cells and inducing a state known as syncytia. To review, syncytia is when multiple cells fuse together to create an abnormal large cell that has multiple nuclei. The presence of syncytia within a smear, when you're looking at a microscope, is a strong indicator that there's some kind of disease state present within the human being or within the patient. I loved figure 18.4 from your text. It shows that the virus will first dock with the host cell. Excuse me. After that virus docks with the host cell, oh, there we go, got it out. Its single-stranded RNA-based genome, or the ssRNA genome, is going to be bound with reverse transcriptase. Reverse transcriptase is then going to produce single-stranded DNA. That single-stranded DNA is then going to be turned into a double-stranded, or is going to be completely matching or base pairing to the single-stranded RNA. That single-stranded DNA is then turned into double-stranded DNA. That double-stranded DNA is then going to be embedded within the nuclear genome of the host. And then at a later period in time, later on, after an indeterminate period of time, that viral DNA that's been embedded within the host genome is then going to be used to make messenger RNA, which then produces viron particles, which then can make the new virus, which will then leave the host cell. And because this virus integrates itself into the host cell, and because this virus is incredibly mutation prone, it stores its genetic information as single-stranded RNA, it's very, very difficult to come up with treatments to combat HIV. We find that HIV is primarily transmitted through sexual intercourse. That is the single largest factor that transmits HIV. It also can be transferred through blood-to-blood products or blood transfusions, or anybody who shares a intravenous needle or IV drug. If you share a dirty needle, you'll take blood from a potentially infected patient and introduce the virus to an uninfected patient. If a woman is infected with HIV, it is possible for her to transmit the virus to her child while the child is in utero, or during the birthing process, or during breastfeeding of the child. Modes of transmission for HIV are going to be very similar to the hepatitis B virus, with the exception that HIV is not a robust viron particle. It can't survive for a very long time outside of the host. It needs to get back into the host environment very quickly. HIV is very sensitive to disinfectants. Bleach, alcohol are two common disinfectants that can be used to combat HIV. But generally speaking, you don't want to put bleach or alcohol on any kind of contraceptive product. So nonoxynol 9 will be used for contraceptive products that are going to be resistant to HIV. Our virus, or viron particle, is not transmitted through saliva. There are very low concentrations of HIV viron particles within saliva, but those concentrations are so incredibly low that they, generally speaking, do not cause transmission of the disease. Any kind of a healthcare worker should be aware that that fluids that come from a patient could potentially be HIV infected, or could potentially cause HIV to be contracted. Some of these fluids include amniotic fluid, synovial fluid, or spinal fluid. So as a future healthcare provider, at least most of you in the class are going to be future healthcare providers, please, please, please wear your goggles, wear your gloves, wear your face shield, use personal protective equipment. I can't emphasize that enough. Semen and vaginal secretions are going to harbor the free virus, or 3 viron particle, and are also going to contain white blood cells that contain the viron particle as well. This is a significant factor for why sexual intercourse is the primary mode of transmission of the HIV particle. We found that HIV has been isolated from saliva, sweat, tears, urine, but the concentration of those viron particles are so low that they aren't considered a source of infection. However, because breast milk contains a significant number of white blood cells or leukocytes, breast milk is a potential source of infection from mother to child. A neonate or newborn that has escaped infection prior to being born could potentially become infected by breastfeeding from an infected mother. Generally speaking, HIV needs to get into the body to cause infection. That's pretty generic or straightforward. HIV can get into the body primarily from fluids associated with sexual intercourse, or from blood exposure, or less commonly through direct blood exposure from needles or sharing IV drugs. Once that virus gets into the body, it can directly infect a macrophage within the bloodstream, or if it's going to be associated with the skin or a mucous membrane, it will infect an antigen-presenting cell, and then that antigen-presenting cell can get the virion particle into the bloodstream. And once that virion particle gets into the bloodstream, it can start actively infecting and reproducing within the leukocytes of our body. The AIDS epidemic started within the United States within the early 1980s. Globally, it's believed that AIDS entered the human population in the 1950s in rural Africa from a host monkey population, and then it took about 30 years to work its way from Africa to the major cities, to the airports, and then to the United States. Currently, it's estimated that the number of people who are infected globally with HIV are between 32 and 38 million, with approximately 1 million infected individuals in the United States. Right now in the United States, we have about 300 million people for the US population, so approximately 1 out of 300 people are infected in the United States, or about 1/3 of 1% of the US population. The World Health Organization has estimated that there are going to be about 2 million new infections in 2009 alone, and that a large number of the people that were initially infected haven't begun to yet show symptoms. Remember, once HIV infects the human, there's that indeterminate period of time, that unknown number of years that will pass before HIV manifests itself as AIDS. And this is one of the major problems associated with tracking and preventing this disease. An individual can become infected with HIV and continue to have sexual intercourse with many other individuals, transmitting HIV to those other individuals before the initial carrier even knew they were infected with HIV, because it hadn't developed into AIDS yet. Global initiatives right now have meant that many more people within developing countries are receiving life-saving treatments that have prolonged that indeterminate period of time, that have caused the period of time from HIV to turning into AIDS to increase. However, the number of new infections worldwide is still growing faster than access to drugs that can combat HIV/AIDS, and the mutation rate of HIV/AIDS is also outcompeting the development of new drugs that can resist or combat HIV/AIDS. Worldwide, heterosexual intercourse is the primary mode of transmission. Within the United States, that isn't necessarily the case, but if we look within Africa, the continent of Africa, heterosexual intercourse is by far the most common method of transmitting HIV/AIDS and causing new infections. Within the industrialized world, the overall rate of heterosexual infection has increased dramatically, particularly within black females. The rate of HIV/AIDS increase in black females has been outpacing all the other rates of increase in the United States. Approximately 24% of all HIV infections in the United States in the year 2014 arise from from unprotected intercourse from a partner of the opposite sex. The remaining 76% of new HIV/AIDS cases in the United States in the year 2014 or 15, I'll check on the next slide, were from intravenous drug use or unprotected sex with a partner of the same gender. And we look at the data, approximately 1% of the population who are antibody positive for HIV never develop AIDS. In other words, 1% of the population has natural immunity to HIV/AIDS. These are non-progressor individuals. So the most recent data that I was able to pull for you was from the year 2014, and I got this from the CDC website. This was not in your textbook. If we look at the 3 biggest causes or 3 biggest demographics that received new HIV/AIDS infections in the United States in the year 2014, we have black men who had sex with men, white men who had sex with men and Hispanic/Latino men who had sex with men. The reason the CDC uses the term men who had sex with men is because the CDC, Center for Disease Control, is more concerned about risky behaviors than it is concerned with someone's sexual orientation. Within black heterosexual women, though, they represented the fourth biggest cause or biggest increase in HIV AIDS cases in the year 2014 in the United States. And this represents a very small subset of the overall United States population. So if we look at this graph, there is a disproportionately large number of HIV cases originating within populations of men who have sex with men compared to individuals who do not have sex with the same gender. And if we also look at the data, we can see that there's a disproportionately large amount of HIV AIDS cases manifesting themselves in black heterosexual women and black heterosexual men. So if we were to look at it in terms of a lifestyle habit, men who have sex with men are the single biggest risk factor. And if we were to look at it in terms of an ethnicity perspective, individuals that have a black ethnicity also represent a disproportionately large percentage of the disproportionately large amount of the new cases. To treat an HIV-infected mother, we're going to give that person an anti-HIV drug. This anti-HIV drug has caused the cases of maternal to infant transmission to be dramatically reduced. This is a good thing because, generally speaking, most women don't want to cause their children to develop HIV AIDS. Based on the current regimens, the transmission rate from mom to child is approximately 11%. Some studies that have involved multiple drugs being prescribed at the same time have gotten this number down to as low as 5%. That's good news. Right now, the best way to combat HIV AIDS is to prevent new infections from occurring. It's also been suggested that if we could give the mom a protease inhibitor, we can reduce the transmission rate even more. The downside is that protease inhibitor is going to have a lot of nasty side effects. So protease is a general class of proteins or enzymes that breaks down proteins within our body. Proteases are very important for our digestive tract. And if we give mom a protease inhibitor, yes, the virion particle will have a much harder time reproducing in her body, but she'll also have a much harder time digesting proteins within her body. So sometimes the side effects may potentially be worse than the disease itself. Untreated moms or untreated mothers have approximately a one-third rate or one-third chance of passing HIV AIDS onto their child. So treatment can lower that transmission rate dramatically. If someone's diagnosed as having HIV, then they've tested positive for the HIV, the human immunodeficiency virus. This diagnosis is not the same thing as having AIDS. AIDS is defined as having your T lymphocyte count drop below 200 cells per microliter of blood. Most of our viral testing procedures are going to be based off the immune system. We're going to use antibodies to separate the virus from serum. We used to use ELISAs, which was an older screening method. Now we typically are going to use rapid antibody tests or latex agglutinations to test for the HIV pathogen. There are some at-home testing kits that are starting to hit the market. They are more cost-effective but less reliable. Generally speaking, the tests are going to be accurate, but approximately 1% of the time there's a false positive. And depending on the availability of the test, sometimes the healthcare provider is just going to base the diagnosis off the presence of those indicator diseases that are typically associated with someone who had HIV AIDS, as opposed to a positive result on the test itself. The follow-up test is a little bit more involved. It's the Western blot analysis. Western blot analysis is a way to test for this presence of very specific proteins within a sample. So it's going to test for very specific anti-HIV antibodies. Recall, an antibody is a protein of the immune system that is going to be produced in response to a specific antigen. We typically use the Western blot follow-up to rule out that 1% false positive rate, to just verify. We can occasionally have false negatives. Those false negatives are usually going to occur before or the onset of the detectable antibody concentrations. So after the patient has been initially infected with the HIV virus, it takes a couple weeks for the antibody concentration to develop to a testable concentration within the patient, depending on their individual immune functions. And if they are administered the test before that antibody concentration has risen to the detectable level, or very recently after exposure to the virus, they are going to have a false negative. Therefore, if a patient has a false negative result, but they have a strong suspicion or a strong hunch that they've been exposed to the virus, there should be a follow-up test 3 to 6 months later just to confirm that negative result. Occasionally, blood and blood products are sometimes tested for HIV antigens as opposed to HIV antibodies. The presence of HIV antigens within the blood is going to occur much more rapidly after infection compared to the presence of HIV antibodies, which means that we can test and get that positive result quicker than we could when we looked for the presence of antibodies. Within the United States, to be diagnosed as HIV positive, you first need to test positive for the virus. To be diagnosed with AIDS, you first need to test positive for the HIV particle, and then your CD4 count needs to drop below 200 cells per microliter. Or the alternative is that CD4 positive cells need to make up less than 14% of your overall lymphocyte profile. That second criteria is more difficult to perform. And then finally, the third criteria is if you have those diseases that are associated with AIDS. And this is the easiest one to confirm. So if someone tests positive for HIV and then starts to experience the diseases associated with AIDS, generally speaking, they're going to be called AIDS positive. So to prevent to combat HIV AIDS, the single best method is prevention right now. We do not have a cure. If someone is positive for HIV AIDS, do not have sexual contact with them. Abstaining from sex is the most obvious and effective prevention method for an individual who is HIV AIDS positive. However, if someone is HIV AIDS positive and they find it just too difficult to abstain from sex, there are certain behaviors that they can use to help minimize the transmission rates. They should have a barrier used. Generally, this manifests itself in the form of a condom. All condoms should have non-oxyl 9 present on them. And it's found that male condoms work better than female condoms, generally speaking, because male condoms are better understood and easier to apply than female condoms. Also, another way to help prevent the transmission of HIV AIDS is to be a little bit of a worrywart. You should, unless you have confirmation otherwise, always assume a sexual partner is HIV AIDS positive. Err on the side of caution. Another thing to do is to avoid intravenous drug use. And if you are using intravenous drugs, please, please, please do not share needles. Another thing you could use is pre-exposure prophylaxis. So if you are going to knowingly pursue a sexual relationship with someone who is HIV AIDS positive, you can start receiving treatment for the disease before you even develop or contract the disease. Another big way that this viron or virus gets into the body is when there are small tears in blood vessels. So in addition to using barriers, another thing that can be done is that barrier should be paired with a lubricant. This is particularly important if this involves penetration of the rectum and anus with a foreign body. The mucous membrane of the rectum and anus is not as thick and robust as the epithelium of the vaginal canal, and that mucous membrane of the rectum and anus is more prone to micro tears, causing the virus to have easy access to the bloodstream. There is no cure for HIV/AIDS, and I cannot emphasize that enough. Earlier this semester, when I was on the CDC website, I was looking at the diagnosed rates of HIV/AIDS within the United States, and in most demographics, we are actually having an increase in HIV/AIDS diagnoses. For a while there was actually a decrease in new cases within the United States, but there's been an increase in risky behaviors that has been associated or correlated with an increase in new infection rates within the United States. Thankfully, though, even though there is no cure, we've had new drugs that have hit the market that have prolonged that period of time from infection with HIV to the development of AIDS. And that's dramatically increased the quality of life for many people that have HIV. The downside right now is that much of the world is far too poor to afford those drugs. So some challenges are making the drugs more widely available and developing delivery mechanisms that are more affordable and practical. And I might add, coming up with drugs that are more effective as well. New drugs mean new lines of attack, means that that would mean that we'd have new combinations to combat the virus with. There are clear-cut guidelines to treat patients that have HIV. These guidelines are being constantly revised as new drugs hit the market. If we look at Triumec is going to contain an integrase inhibitor. This integrase inhibitor helps to reduce the chances of the viral DNA being incorporated into the host genome, and it also contains 2 separate reverse transcriptase inhibitors. So it combats the virus 2 different ways. It helps to prevent the virus from going from RNA to DNA, and it helps to prevent the virus from integrating its DNA into the host genome. This drug should be given as soon as a patient receives a positive diagnosis of HIV. Anyone who has HIV should receive a wide array of drugs, because as you have that wide array of drugs, that means the virus will need to mutate in more different ways to become resistant. And as you add more and more prerequisite mutations, it becomes statistically more unlikely for the virus to be resistant to an ever-increasing number of drugs. We also should focus on treating those opportunistic infections that develop in the patient. As the patient transitions from HIV to developing full-blown AIDS, we should focus on treating the symptoms of their compromised immune system in addition to treating the HIV itself. If we were to look at some of the current drugs that are on the market, we have drugs that help prevent the virus from fusing with the cells. We have drugs that help prevent the virus from producing DNA. We have drugs that help prevent viral proteins from being processed by proteases. So we have fusion inhibitors, we have AZT, which is a reverse transcriptase inhibitor, we have protease inhibitors, and we also have the integrase inhibitor. This integrase inhibitor helps prevent the viral genome from being incorporated into the host cell's nuclear genome. So we're attacking HIV on multiple fronts. Before it gets into the cell, before it replicates its genome, before it processes its genome, and before it hides or integrates its genome within the host cell. And as new drugs hit the market, we can attack the virus on these 4 fronts multiple different ways to help reduce the development of AIDS from HIV and extend the lifespan and the quality of living for individuals that are infected with HIV. So, concept check class. HIV is transmitted primarily through homosexual intercourse, heterosexual intercourse, non-sterile needles, blood products, or mother-to-infant transmission. If you don't know the answer, that's okay. Go ahead and rewind the video and check, or you can rewind, or you can flip back in your PowerPoints, or check your textbook. Get me an answer. 5, 4, 3, 2, 1. Within the United States, most new cases of HIV are going to be within men who have sex with men or within homosexual intercourse. And this is a disproportionately large representation of the population. The next largest population that is going to develop HIV/AIDS is going to be individuals of African American or black descent. But the single largest source of transmission is with homosexual intercourse within the United States. Worldwide, though, so this is going to be within the USA. Worldwide, so we'll say WW for worldwide, the most common mode of transmission is heterosexual intercourse, and this is primarily in the continent of Africa. If you have any questions about this material, please feel free to post them on the discussion board or shoot me an email. Happy studies.